pain learning series session of 2023 in this May. I remember thinking about the 21st century, and we're already almost a quarter of the way through it. Um, so, um, but what we're going to talk about was the procedures that patients get for chronic pain, particularly for back and neck pain, epidurals, facet joint injections, radiofrequency steroid injections in joints and in different places, Botox and things like that. What they do, and are they any help for pain management? Um, and do you want the quick version or the long version? I'll tell you. I don't know. Hang on a sec. I'll build up to it. Um, so the uh, the, the sort of blocking nerves goes back to, originally it was neurosurgeons who would actually expose nerves and drop cocaine onto them at the end of the 19th century and beginning of the 20th century, and then there was the development of the hypodermic needle, and you could do nerve blocks without having to cut people open, uh, and so anaesthetists got interested in that because we like doing things like spinal anesthetics and epidurals and nerve blocks. And so that's really how anaesthetists got involved in running pain management services in the first place. Uh, and uh, so certainly that was most what I was interested in when I started off in pain. So when I was a junior anaesthetist, I would go along to the pain clinic, and I would see a consultant asking some obscure questions, and I wasn't really sure what was going on at all. And then they would make a decision about whether to do some acupuncture or a procedure, um, and it was all a bit of a mystery to me. But then I learned some more and got very keen on doing epidural injections and facet joint injections, and I did that for quite a few years. But as we'll maybe find out from uh, the talk, um, it's really looking at a biomedical approach to pain, looking for some sort of structural thing that we can block and and then help us to make a diagnosis. And so if we think about people who have got chronic pain, about 1 in 3 in the population, and more than half of them have got back and neck pain, um, and usually we say that is non-specific uh, back or neck pain, which means that it's not really tied down to a specific structure. And one of the issues I think with injections is we're thinking about, doing an epidural where we're going to affect a nerve root, or we can do a facet joint injection where we, isolate a particular facet joint. We say that was the thing that was causing the pain. Um, so, and we know we've got lots of evidence now that people get changes on the way that their scans look as they get older, which is mainly to do with age-related changes, loss of elasticity, extra bone growth, which is repair processes, and we see the same amount of changes on people that have got uh, back or neck pain and people that don't have back or neck pain. So. Um, so with epidurals and nerve root injections, we're using usually mixtures of local anesthetic and steroid. And a local anesthetic, everybody will have had local anesthetics if they've had fillings or anything else like that. You know that they work pretty quickly. So you're getting an effect with some reduction in pain if you've got the local anesthetic in the right place near to the nerves. That happens within a few minutes. Um, and then the theory of mixing in the steroid is that that's going to reduce inflammation if there's inflammation in the nerve root that's causing the pain. And usually we would expect that to be radicular pain, where we would find pain going all the way down an arm or a leg in the distribution of a nerve root. And so that's usually a narrow band, and it's shooting or burning or um, uh, neuropathic feeling. So it can be cold or um, uh, can have itching as well, or or sensitivity to cold. Sometimes we find that there's actually numbness, but if the nerve root is compressed more, um, and we might find some weakness. Now, we call that where there's a difference in the function of the nerve in the arm or leg. You would call that a radiculopathy rather than radicular pain, because there's a this change in function of the nerve as a result of its compromise, usually up in the spinal cord, so it's where it's coming out of the intervertebral foramina, and there might be a bit of a disc, or there might be increase in the amount of bone that's in the articular processes in the facet joints that's causing a restriction in the amount of space that there is for the nerve. And then the steroid is also thought to have a bit of a local anesthetic effect. So um, But the thing I couldn't understand when I was a trainee anaesthetist was these things don't actually last for very long, but people say they get their pain relief, which lasts for months and months afterwards. And if we think about how long we're wanting the pain relief to last for it to be worthwhile, then there's not really a very good guideline or agreement on that. So um, certainly I know that in the pain service where they do procedures over in Galsby, they want things to last for 4 or 5 months to make it worthwhile repeating them. Uh, and But in general, we would say that if you get steroid injections of depot steroids more than 3 times a year, then it's going to have an effect on your own uh, natural steroid production, your adrenocortical production, and that might affect your immunity and fluid handling and blood pressure and all sorts of things. Uh, so um, so we know that the short-acting local anesthetic lidocaine might last up to an hour. Bupivacaine might last a couple of hours if we put it in an area where there's not too much reabsorption. Um, and the depot steroid, I couldn't find really good information on how long that hangs on in the system, but it looks like about 10 days, 9, 10 days at the very most. Um, and dexamethasone, which I'll explain, is a soluble steroid. So the depot steroids are in an emulsion, which means that they're not really a solution. They've got particles in them, same as emulsion paint, and they hang around for quite a long time. But there's some disadvantages, which has led to more people using dexamethasone, which is a soluble steroid, more recently, and that's lasting about 8 or 12 hours. I hope Chris is going to correct me if I get any of this wrong, or Lindsay. um, and So where we're putting these injections um, is if we're looking at the spine from the back, then we can feel our spinous processes underneath the skin, and then there are the discs around the front and your facet joints at the back. And so with an epidural injection, we're usually trying to get the people to curl up a bit so that it opens up the spaces in between the spinous processes, and we pop in a wee needle right in between the spinous processes. It gets to the ligamentum flavum, which is a really tough elastic ligament, and we just try and get the needle to just go through that. We feel lots of resistance when we're going through the ligament, and then the resistance disappears as soon as we get into the epidural space. And the epidural space is outside the dura. The dura is a really tough membrane that surrounds the spinal cord and your brain, and protects it from any damage. And inside the dura, you've got your spinal fluid. So we don't want to go all the way in there, because if you go through the dura, then you get a leakage of CSF, of the spinal fluid, and you can get a really nasty headache from that, a dural puncture headache, where if you try and stand up, it gives you a terrible crashing headache. So I've only done that a couple of times in many, many years, I'm glad to say. Um, so, so that's one approach to the epidural space. But more recently, over the last sort of 15 or so years, there have been more and more anaesthetists and interventional pain specialists who are doing intraforaminal epidurals. So these bits of bone here are called the lamina, in between the spinous process and the articular process where you've got your facet joints. So that's the lamina, and that's called an interlaminar injection or epidural. But round the side, you've got the intraforaminal epidural, and so we think if there's a bit of a disc that's bulging out there and it's irritating a nerve, and you can, if you've got a patient who's getting spinal surgery to make more space for a nerve, you can see that there's some redness and inflammation in the nerve. And if we look at animal models, then inflammation in the nerve seems to cause the same sort of well, we don't know what sort of pain your rats or mice are behaving, but they don't like putting their foot down on the floor, and they protect it. So it's obviously very sensitive. Um, so if you're doing your interlaminar injection and there's a disc bulging out here, then the thinking is that, well, the solution might not get round to the affected nerve. And so we would do an interforaminal injection instead. Um, and then when we're doing facet joint injections, then there's a couple of different approaches. So the way I was taught to begin with was to you get these bendy needles, and you try and bend them into the actual joint itself. So you're doing the injection into this little space, and there's some disadvantages to that, which I'll tell you about later. But nowadays, most people would do injections which are going to the nerves that are going to the facet joint. So once if we think about going around the side of the spine here, where the nerves come out, the intervertebral foramina, that's sort of a space that's only about centimetre across in the lumbar spine. Then we've got a primary posterior branch which comes round to supply the facet joint from below and comes down from above. And so what most people would do now is they would do an injection to these nerves as they come round the transverse processes. And but you have to do 2 injections. And if you've done that and your pain goes away, then you can think about doing a radiofrequency lesion where we put in a probe that heats up the nerve and basically cooks it. You're wanting to try and destroy part of the nerve, and it's mainly sensory. Uh, I think the trouble with facet joint injections, from my point of view, is thinking that the way that these uh, so there's the intervertebral foramina there at the side of the spine, and the nerve is coming out there. The primary posterior branch has got a medial branch which comes to the facet joint, but it also supplies quite a lot of these muscles. And so I think that's where some of the confusion about facet joint injections maybe comes from. Uh, so, um, so what about Uh, other procedures are things like trigger point injections and injections of botulinum toxin. So, and when I was a trainee anaesthetist, I would see a lot of trigger point injections where people would inject some local anaesthetic and steroid into a really tender bit of the muscles. That's where you find there's actually a lump you can feel under your fingers. And often people have got them at the lower back and the posterior superior spine, or in their neck at the lower end of levator scapula, where the muscle comes down from your neck and joins into the corner of your shoulder blade. And so you do these injections of steroid in there, um, and there's not really any evidence that they work, unfortunately. And botulinum toxin works completely differently. Rather than uh, using local anesthetic, it's using the toxin which binds to the acetylcholine receptors in the neuromuscular junction. So it's the same stuff as um, Amazonian Indians would be using uh, uh, to um, uh, to poison their monkeys and so on. No, it's not. It's not at all. That's curare. ignore that bit. I'm getting mixed up. Who uses Botox? Well, obviously cosmetic. People use it to iron out people's wrinkles. Um, and so actually, it wouldn't be any use for getting the monkeys out of the tree because it can take about 3 days to work. Whereas curare, you'd be hanging about for quite a long time, following the monkey about, waiting for it to get a wee bit paralyzed. The curare that they use there in the Amazon, that works very quickly and they drop like a stone. Um, so, um, so Botox is very popular to treat these muscular trigger points, but it's taken about 3 days to work, and it's lasting for about 3 months. And where we've got a whole load of different muscles, sort of your 12 or 14 different muscles around about your neck, controlling your neck movements, and we're paralyzing some of them, then I'm not really sure that there's been a really good analysis of that, if that's going to have unintended consequences. And certainly it seems to become less effective the more often it's done, and people can develop antibodies to the botulinum toxin as well. Now we'll come back to talking about intra-articular and subacromial injections. Occipital nerve injections are done for people that have got a shooting pain that's going from the back of the head right around the greater occipital nerve. And again, it's usually a local anesthetic and steroid injection. And so the neurologists would do a fair number of those, and we can do them in the pain clinic. Um, uh, I find they've got, the thing with all of these procedures is that they can have an effect, and then you're back where you started once it's worn off. And uh, I'll come back to that bit in a wee bit. Don't worry, I've not got a very long talk today. Um, uh, so looking at the evidence, um, the most research has been done for caudal epidurals. So that's rather than the interlaminar epidural that I was showing you before. That's right down at the bottom of the sacrum. There's a tough transhiatal membrane that goes over the bottom of the sacrum where our tail would have been if we had a tail, and you can put a little needle in there without too much difficulty, and the local anaesthetic spreads up the sacral part uh, of the spinal canal, and yeah, but you have to inject quite a large volume, so you're putting in sort of 30 or 40 mils of local anaesthetic there, where you probably only put in 10 or 20 mils in interlaminar epidural, and you would only put in less than 5 mils, a couple of mils for intraforaminal epidural, where you're right in that sort of narrow bit where the nerve comes out from the side of the spinal cord. So this is a study from a Journal of Interventional Pain Medicine, and so I give this quite a high rating because if you get published in the Journal of Interventional Pain Medicine, most people are reading that are quite keen on doing these injections, and I think we'll come to a bit later. Is there's quite a bit of bias and less than scientific thought about all these sorts of things. So they were looking a systematic review of caudal epidural steroid injections in low back pain or the radicular pain where there's the nerve root pain going all the way down the leg. And they were looking for evidence that was reduction in pain by 50%. And they were looking to see if there was improvement in people's function, reduction in analgesic use, whether they avoided having spinal surgery or going to the doctor so much, and mean improvement in pain. And so they screened a lot of research papers, 364, but there was only 23 that had the criteria that they were looking for there. And when they analysed those, they found that the only thing that was moderate evidence for, so they would grade it to high, moderate, and low quality evidence. The only thing that had moderate evidence was for 2-day infusion through a catheter or into the caudal epidural space. and there was very low quality evidence for other techniques. And I think I'll maybe come back to is that in all of that research, there was only one randomized controlled trial. So we know that we want to make sure that if we do have biases, that they're not influencing the outcome of any research. And in order to do that, you have to be able to randomize patients to either have the treatment or placebo, or if you're comparing two treatments, then you have to randomize to one of the two treatments. Then you have to have an independent observer, not the operator, analyzing the results. So if I was to do a randomized a survey of the anesthetics I gave today. Having given all of the anesthetics, I gave them all a really high mark. They were all really good, and the patients are all happy post-operatively. But if somebody else was to come and have a look at it, they might say, "Oh, well, but like one of them needed some more painkillers after they woke up," and so on. So, as the case in a lot of research that's published, the final bit says there's more research needed. In other words, we've been doing things like epidurals and caudal injections since the 1940s. So around about 80 years of practice now, and we still don't have clear evidence of whether there are any benefit to patients, which it's a shame when you look at. I think first of all, that is difficult for doctors to deal with. It's difficult for patients to know what to do, but also there's all these research studies, 364 studies done on lots and lots of patients, where they haven't actually designed the study well enough to get a meaningful result from the research. So it's actually subjecting patients to experimental procedures without, having a scientific method. So the interlaminar epidurals and the nerve root injections. This is, I think, from last couple of years ago, from 2021, and this is from the Clinical Journal of Pain, which is an American journal, and again, it is quite biased towards interventional pain medicine, and so they found no clinically relevant effect. Fuller analysis found a clinically relevant effect. So 36 out of the 40 analysis they did found no clinically relevant effect, but 4 found a relevant effect on pain and health-related quality of life. But the certainty of this evidence was either low or very low. So again, things come out as perhaps statistically significant, but the difference that can be statistically significant could be less than 1 point on a 10-point pain scale. So their conclusion was that epidural steroid injections for patients with lumbar radicular symptoms of the radiating pain down the leg there wasn't enough evidence to say that they were clinically relevant. So and the reason that the research has, I think, been in such a poor state is that most of the research that's been done has been observational and retrospective. So they're looking at what happened to their patients that came to the clinic, and they'll study maybe quite large numbers, but there's no randomization or blinding, and often they're looking back at what's happened rather than saying we're going to do something and see whether it has an effect. They're looking back to say, oh, we did that and it was great. Sorry, that's being maybe a bit cynical. So what about some of the things that might happen during an epidural injection? So we talked about the dural puncture earlier on. So where we're putting the epidural needle up the middle of the epidural space, then there's about between a half centimeter and a centimeter that we can go before we puncture the dura. But if we're up in the neck, then in fact it's maybe just a millimeter or two. And so, and in as you go down your spinal cord, it starts off quite fat up at the top and takes up most of the spinal canal, and then it ends up sort of tailing off around about between L1 and 2, so between the first two lumbar vertebrae, and that's why we do spinal anesthetics lower down so we don't spear the spinal cord. And so at this level, there's not so much space to get into the epidural space. And if we go and do the um, selective nerve root injection or the interforaminal epidural, then again, we've not got much space, but we've also got the vertebral artery and the vertebral veins really close by. And so what can happen is if you get your injection into the vertebral artery, which usually when you're injecting, you would aspirate first, you would suck back to see if there's any blood coming out. And the trouble with the vertebral artery is it's not a very wide bore thing, so you can sometimes not aspirate, but actually be in the artery. So when you inject, their steroid solution goes into the artery, into the arteries which go into the spinal cord as well. Uh, and so that has been a cause of some really serious outcomes for patients, and in fact it's led to our other consultant in NHS Highland deciding not to do any further procedures in the neck, as the hospital he does it in is about an hour away from the intensive care unit. So, so people that have ended up with paraplegia um, and also severe brain injury and death if the vertebral artery goes up into the circulation, which goes off to your brain, of course. Um, so that's a really serious side effect. We can put the needle right into the nerve, and if we inject into the nerve, then it's not just the cutting effect of the needle, but the solution will expand the nerve and destroy it. And if we do that in the spinal cord, then it gives people really serious spinal cord injury. Um, and uh, and then we can obviously cause infection if we're not using a sterile technique. So, and as you can see, there's all these the spinal cord in your central nervous system is a really vascular structure. So most dangerous in the neck, and that's where most of the reports of people coming to really serious harm after epidural or interforaminal epidural selective nerve root injection come from. But in the lumbar area, you have an artery which is quite variable in where it runs, the artery of Adamkowitz, and so if you inject into that, then you can get the central spinal cord problem. You get an infarction of the spinal cord and end up with paraplegia and all sorts of neurological symptoms. So remember at the beginning we were talking about the stuff that we inject, and most people would inject a depot steroid, which is an emulsion. So that's got particles in it, and that's thought to be much more damaging if it goes intravascularly because the particles will block up all the capillaries and cause more damage. So a lot of interventional pain specialists now use dexamethasone with the reasoning that if they do inject intravascularly, at least it's a solution and it's not going to block up the blood supply to the spinal cord. Uh, so, um, so with the facet joint research, there's similar problems as in that most of it is observational and retrospective and non-randomized. And the I think a difficulty can be that if you're looking for a facet joint, the pain, and you're thinking that I'm, expert at doing facet joint injections, then it's actually really difficult for um, people to accurately diagnose facet joint pain. So there was a big study in anesthesiology, the American Journal of um, Association of Anesthetists, and they found that doing the injections, they could make the pain go away, but it was no predictor of whether then burning the nerves afterwards with the radiofrequency probe was going to be effective or not. And as I was saying earlier, you can either inject into the joint or around those medial branches of the posterior primary ramus. But if you inject into the joint, which is what I was taught to do, then it's only less than a 2 mil space. So if you inject into it, you can rupture the capsule of the joint. So if they didn't have a problem with their facet joint beforehand, then they probably have one afterwards, because you've destroyed the capsule, which is keeping the synovial fluid in the uh, in the joint. So and then this trial came out in 2017, the MINT trials, and it was a Dutch group of researchers who decided, right, well, we've had all this non-randomized observational stuff going on for years. We need to do a randomized double-blind controlled trial. And so they did, and they did with a reasonable number of participants, almost 700 patients who either had the radiofrequency treatment where they're burning the nerve to the facet joints or to the sacroiliac joints, or they had a standardized exercise program. Both groups got the exercise program, but one of them got the procedures. And so the differences in your pain scale out of 10 was 0.18 out of the 10-point scale for the facet joints and 0.71 for the sacroiliac joints. So less than 1 point difference in the pain scale. And so they didn't feel that was a clinically significant benefit. And there was a big furore about it. Um, Lots of people saying, well, they didn't put the needles in the right place, so they used the sort of slightly narrower, used 20 gauge instead of 18 gauge needles, and you see where their X-rays are, they weren't numbing the nerves, but in fact, the the criticisms of the trial were really quite sad to read, and they were citing, small observational studies and uh, sort of expert opinion rather than any other. If you've got a really well designed randomized controlled double blind study, you want to refute the findings of that with another well designed study rather than saying, well, I don't think these guys know how to do facet joint injections or the radio frequencies, because they were all experienced pain clinicians, the people that did the study. So, so people don't like it when you find that something's not much use, especially if they've got, really good at doing it. If they see patients, I think, getting uh, loads better after they've had these procedures, and the patients are really grateful. And it can, in a private health system, it can be, a lot of the pain specialists' practice that they're doing. Um, so I was hoping Neil Wright was going to come along, because he talked about this when I was chatting to him about a patient with subacromial injections. That's where you get your anterior shoulder pain, and you've got your supraspinatus tendons just running under the acromion here. And so you get stuck here, and then there's a painful bit, and then you can lift your hand further up a wee bit. And so a lot of people think, well, that's down to inflammation in the supraspinatus tendon, and you can inject some local anesthetic and steroid around that, and it makes it loads better. So this was from a study which must be about 7 years ago now, which there's a really good design of study where they either injected the local anesthetic and steroid in here, and then just local anesthetic in the patient's bottom, or they did it the other way around. They just injected the local anesthetic here and the local anesthetic and steroid in the gluteal muscles, and they didn't find any difference between the two targets for the steroid. So again, unfortunately, not really good evidence for that. And then Becky sent me this paper where it was looking at intramuscular versus intraarticular steroid injections in people with knee arthritis, and so they found if they either injected the steroid into the knee joint or into the thigh muscles, that the IM steroid was a bit less effective in reducing pain at 4 weeks, but then there was equivalent effect between IM and intra-articular at 8 and 24 weeks after injection. And the other things they looked at were like activity and the participation in sport, joint symptoms, quality of life. They were the same between the two groups. So so I think from my point of view, I think there's not good research on the effect that these procedures have on patients. And I was hoping I might get some feedback about what you think about it. I think from the positive angle, if we do something which helps people to get more active, to reduce their analgesics, or and they are using it as a mechanism to get better by themselves rather than depending on the procedure to make them better, then that might be really good. But I've done quite a lot of searching and I haven't really found any research into patients' experiences or beliefs about that. Um, and then the negative side of things, I think there's quite a lot of risks to these uh, procedures, and especially with intra-articular or supraspinatus or other uh, tennis elbow, different kinds of injections like that. Then we know that the steroids actually increase the risks of tendon ruptures and cartilage damage. By the local effects. Um, so, we might be relieving the symptoms, but we're actually increasing the likelihood of a long-term problem. Um, I think the steroids have got side effects. So you see patients who are diabetic get all sorts of problems with the blood sugar after you've done a steroid injection, and uh, uh, and I think they can definitely have an effect on your mood as well. So steroids tend to uh, give people an up, and even uh, in sport. So my greatest disappointment in cycling was I thought for a long time that Lance Armstrong was a very decent chap and he wasn't cheating at all, but of course he was. He was pumped full of all sorts of stuff. But a really interesting study that they did in Holland with track cyclists was to either give people steroids or placebo, uh, and or EPO, and they didn't see any difference in performance. They all got a placebo effect, and the actual drug effects of steroids and EPO weren't any performance advantage. Um, so, but I think one of the things is, in the Michael Nicholas from North Shore in Sydney's diagram of how people have repeated treatments and they fail and they get the disappointments and letdowns and they're up and down. They're if they have so I've been talking to a lot of people who are not getting the neck procedures anymore, and I'm pretty much 100% getting agreement from them that when they've had their procedure, it might feel better for a while, but then it wears off and they've got quite bad pain and they can't do what they want, and they're waiting a long time to go back for another procedure, which I think is a fairly negative experience for them. Um, but I did find one paper on the patient's perspective from 2020, um, which again was a Dutch paper, um, and they had. I was trying to read it with an open mind. I think they were a bit biased, but they got some quotes. They felt that when patients had gone to do a pain management program, they'd been told this is what you got to do, and where they were going to the interventional pain doctors, they were saying, That's got the right bit. So we've found the right area to inject the local anaesthetic and steroid into. So they felt more participating in their pain management, which is kind of the opposite of what I would have thought. And people that felt very down and suicidal, didn't want to kill themselves anymore, um, and people were able to reduce their medication. And so certainly talking to people in the pain service in Highland, um, there's there's a bit of uh, uncertainty in people's minds about saying, should we not do any more injections at all? Um, we're seeing patients coming back again and again, some of them coming for years. When we do the procedures again and again, then we expose people to the risks of the procedures every time. And I think when I see people coming in, so I've inherited some patients from the clinic in Oban, and there's definitely a sort of institutionalization of the patients as they come in. There's the sort of getting ready for theatre. There's a pain which is evoked by the procedure because often we're injecting the local anaesthetic and steroid in an area which is really sensitized already. So it can be quite painful to have the procedure done. Um, and then often patients have a big flare up after they've had their procedure, followed by some pain relief. Um, so I always remember a guy who'd been the president of the British Pain Society telling about research that he'd done in Belfast, and one of his registrars had asked the patients when they were coming in for the procedures, how long is it since your last injection wore off? And he was looking at patients who were allocated to different repeat uh, uh, intervals, either 3 months, 6 months, or a year. And it didn't matter which interval they had between the procedures, it was always 2 weeks previously that the last injection had worn off. So anyway, uh, uh, I've searched for that paper, but not been able to find it. So I thought I was going to be a lot quicker than that. Sorry about going on for so long. Um, uh, what do you think of that? What's your perspective? Um, have you been through any procedures? Yeah, you've been through your operation, Tina. Yeah. Did you have any procedures before that?
No, but when I was in real agony once, I was really struggling to work and struggling to cope with pain, and I just walked into a GP practice on my way home from work because I couldn't cope anymore. And I just said, someone's got to do something. And by chance, I saw a locum GP, an older chap who had come out of retirement, I think. He said, I know, I'll give you an injection. And it went against the grain for me, but I was in so much agony. I just let him, I would have let anyone inject my back because it was so sore. And he gave me an injection, and of course it didn't work. I don't know even what he gave me. I didn't even ask. I just wanted someone to do something because I was so desperate. But no, it didn't work. But at least he listened to me, and he was kind, and he did something. And I think when you're in agony, that's what you want. It's just someone to offer something.
Yeah.
But
Yeah.
I did want to add here, and I'm going to be very ignorant here, so excuse me, but
No, don't worry. Yeah.
Has anybody trialed just, the ibuprofen cream that you can get? You can get a high dose one, I think. Has there been any research on that? In the areas where you are actually injecting, does that have an improvement on people in the same areas?
I think Chris will correct me. I think there's it's recommended in the guidelines for osteoarthritis in smaller joints in hands, feet, and knees. But I don't think it would be effective for back pain.
I think there's quite limited evidence, and that's really why most formularies now will back one usually based on cost rather than anything else. But yeah, I think you're right, Steve. For osteoarthritis, yes, but the actual evidence base for long-term chronic pain is reasonably poor. And a lot of the time, there's probably not a massive difference between placebo or using something like heat or cold therapy.
Yeah. Yeah, unfortunately, there's been a real shortage of capsaicin cream. So that's got it's not terribly strong evidence either, but some evidence for it. So Chris told me that there's some in the hospital pharmacies, but there's hardly any in the community pharmacies. Lindsay will be back earlier on to say that there's a real shortage and difficulty with supply still. Yeah.
We would kind of tend to use menthol and aqueous just as a first line. I don't know what you think about that. Just that's
Yeah.
kind of, if we're getting any of the capsaicin guys in at the minute, because we're aware of it is a bit of a problem, we tend to
Yeah.
just be putting them onto that to try and see if it makes a difference. I think there is some evidence for ibuprofen use, especially for osteoarthritis. There does seem
Yeah.
to be, particularly in the gel rather than actually the tablet formation of it. Seems to be a wee. There's some evidence for that, but yeah. We're kind of going for the menthol and aqueous as the only kind of option, because the capsaicin is really not an option.
Yeah, interesting stuff about cold exposure. I was listening to a couple of weeks ago was that we've got lots more cold receptors than so 10 times as many cold receptors as heat receptors in our skin, and but it's kind of a different mechanism, you would think. So the menthol's acting on your it's the TRPV channel, and the TRPV8 channel is the one that the capsaicin works on. And so, yeah, I'm not sure if they're interchangeable. Sorry, Kathana, you had a question as well.
So, just from a personal experience, it's been really interesting, Stephen, what you're saying. I've had both my shoulders operated on, and prior to that, nursing for years, I'd ruptured both all the kind of super sprays and everything. They persuaded me to take. One time I had 6 steroid injections in a year in one shoulder. And I kept on saying to people, this is affecting my stomach, and it was affecting them. And they're saying, no, it only stays in your joint. It can't affect you anywhere else. And it does. It was horrible. And you know what? I didn't really, until I got my rotator cuffs fixed, it didn't really make any difference to the pain, and it was absolutely horrible. But just a wee thing, it was quite funny. Years and years and years ago, you don't see it so much now. My granny used to have. Do you remember when you used to see the big shiny knees that they used to have before they replaced knees? And she swore by olive oil. And she used to keep a bottle of olive oil beside the fire. And I remember saying to a patient one time, and Karina was with me, and she started laughing. I says, put some olive oil on your hands and rub it into your joints. It's really, really good for your joints. And Karina laughed. She said, where in the world did you hear that? Anyway, that night she went home, and in the BMJ there was a 4-page article on the anti-inflammatory properties of olive oil.
So I think a lot of it, yeah, a lot of it is it's the rubbing, yeah, I think, yeah. So you're stimulating your touch and pressure nerves, and you're maybe activating your pain gate in the same way as TENS, yeah.
But people do come back now and say to me, do you know, actually that actually works? So olive oil, warm olive oil.
Yeah. Whatever happened to snake oil? We don't get that anymore. Yeah. And yeah, I had my shoulder experience where I got this shoulder when really painful, and I couldn't sleep on it, and it was difficult to cycle and lift stuff, and I was away on holiday, and it was really miserable on this holiday. It was like not sunny or nice. It was really wet and cold, and I was on these marble steps, and I was just saying to my son, watch out, these are pretty slippy, these steps. And of course I went straight down the stairs and bashed my elbow, which came up in a massive big bruise, but it made my shoulder better straight away. And but then I got the other shoulder, and that was even worse. And I think people often find that it goes from one to the other. And so I went and saw one of the radiologists who did a steroid injection, and it was great while the local anaesthetic was working. and then it was much, much worse, and I sat up all night not sleeping. I was glad when it went back to the way it had been before, and then eventually it got better by itself. Yeah.
Is there any injections you would recommend in chronic pain?
I'm afraid not really.
No, that's fine. I'm just curious. That was kind of my feeling, was generally that actually there isn't much. But I just wondered if there was any that you thought actually, for trigger finger or,
I think that if something is going to help the patient to actually move, then that's useful.
Just as an add-on
And so, no, I don't know so much about the evidence for trigger fingers, so I wouldn't see those. That'd be the hand surgeons who would see them. So I couldn't say for sure.
But for backs, no.
For backs, I think that it's an area where I would say no, but you can go to plenty of pain specialists in Scotland and around the world who would say that it's really good, and you get patients who respond really well to it. But I think it's the same, or maybe it's just the patients I've seen, maybe my bias, that I see the patients who've got the most distress and the more widespread pain and more catastrophizing anxiety, depression, perceived injustice. They get the higher doses of analgesics, and they also get the injections. And so it seems to be, and I think that's sort of confirmation bias. You're saying now, you're looking for something you can do to fix the patient, and if you've got something that you've done and the patient's really grateful, then it can keep you doing things that don't necessarily have any evidence. But who knows? Maybe there will be further research, and we will come out with something conclusive. They are developing more extended release local anesthetics, sort of liposomal local bupivacaine, which I was involved in getting a study going in Australia, but I don't know whether there's any outcomes from that. I couldn't find anything. Grand. So maybe stop recording.